Well, I've got 7:15 and just wanted to start by saying good morning and welcome all to our inaugural WInnovations webinar, sponsored by the University of Wisconsin Department of Urology. I'm your host, Dr. Kyle A. Richards, and we have a great session planned for you this morning. Now, the purpose of these webinars is to highlight some exciting and innovative work being done within our department at the University of Wisconsin. And we also want to generate some ongoing discussions within the broader urology community so that we can continue to work together to make innovative advancements in urologic care. Now, the format for these sessions will be 20-minute presentations followed by 10 minutes of Q&A that I'll moderate at the end. Please feel free to enter any questions or comments in the chat at any point during the presentation. You can get those kind of lined up so that we'll be able to address those at the end. And our next webinar, I'm just going to share my screen real quick just to pull up who's coming on deck. Our next webinar will be on September 27th from 7:15 to 7:45, featuring Dr. Tudor Borza, who will be speaking on using novel technology to improve outcomes following cystectomy. So we're really looking forward to having Dr. Borza on in September, and we'll have additional webinars to follow in the months to come. So hopefully you'll be able to attend that. And if not, these are all being recorded and will show up on the Department of Urology website. Just want to thank the department for hosting and supporting these events, as well as Christina Bruger, who's our administrator for these events, as well as Steve Hall. So now I'd like to turn things over to Dr. Matt Grimes. Stop sharing my screen here. So Dr. Grimes is a urologist in our department, actually joined our department in 2019 after finishing his reconstructive urology fellowship at the University of Iowa. He's really been a fantastic addition to our department. I've enjoyed having him as a partner. He was a resident here as well. And he is very passionate about his topic for today, which is MRI Urodynamics, the future of personalized medicine for BPH. And take it away, Dr. Grimes.
All right, perfect. Let me get my slides loaded here. Thanks to everyone for joining up nice and early in the morning, and excited to share the results of this work with you. 1 second. Okay, so thanks, Dr. Richards, for the kind introduction, and excited to speak with you this morning about the results of this work to develop MRI as a novel technique to investigate lower urinary tract function and dysfunction. And so to frame this, if I show you just a single freeze frame from a movie like this one, it's hard to know what the movie is about. I mean, we can guess. We see Leo. He looks upset. Is this the one where he fights a bear, or is this the one where he's stuck on a sinking ship? Hard to know. So I often explain to my patients that diagnostic imaging tests like CT and X-ray are kind of like this. They're snapshots in time. They're powerful, but limited. And we have tests that can tell us information about anatomy, and we have tests that can tell us about function, but there's almost none that can simultaneously give us both anatomic and functional information in high fidelity. Or in other words, we never get to watch the movie, at least until now. So here at UW, we've used MRI in order to capture the lower urinary tract in function, in action, to say. And this was a technique that I'll go through some of the details of that allows us to do just that, to simultaneously capture anatomic and functional information. And I think this is really exciting for two primary reasons. The first is that I think this has the potential to supplant and improve the existing diagnostic tools that we have in a completely non-invasive fashion. And then the second reason that I think it's really exciting is that it is a powerful opportunity to advance our understanding of lower urinary tract function and dysfunction, and specifically to address a couple of critical knowledge gaps in non-cancer urology, such as the ones that are listed here that we'll go over in detail. So before we do that, just to take a quick step back and kind of frame the clinical problem at hand, and that is urinary symptoms in aging men, which, as we know, is exceedingly common. And this graph depicts the high and increasing prevalence of these symptoms, including weak stream, urgency, frequency to urinate, and getting up at nighttime with increasing age. So as we can see, these increase kind of in lockstep with age. And in men, these are most often attributed to benign prostatic hyperplasia, or BPH, which is actually a histologic diagnosis, which is near universal in aging men, which refers to proliferation of glandular epithelial tissue, smooth muscle, and connective tissue within the transition zone of the prostate. And the net effect of this is enlargement of the prostate and sometimes stiffening of the prostate. And so the story goes, or the paradigm goes, that, well, BPH, makes the prostate bigger and possibly makes it stiffer. And then that, restricts the flow of urine, or we call that bladder outlet obstruction. And then that, causes bladder dysfunction. And that's what drives, symptoms like LUTs, or lower urinary tract symptoms, which bring men into the office, puts them at risk for urinary tract infections, causes urinary retention, predisposes them to bladder stones, and in extreme cases can cause kidney failure. So due to the high prevalence of both LUTs and BPH, as clinicians, this is common, and we get really good at pattern recognition. And so when we see a man of certain age with a certain pattern of symptoms, we most often attribute these to BPH, and often we're right, but we're not always right about that. And then we carry this patient through a clinical pathway of evaluation, followed by medical and then surgical treatment. And it's important to understand that the mechanism of these treatments, medical and surgical, are focused on relief of bladder outlet obstruction by the prostatic tissue, which is assumed to be the problem, but is not routinely assessed. And then this is where the story starts to get a little more complicated, because puzzlingly, worsening patient symptoms are the most common factor. There are others, but symptoms is usually what drives us down this treatment pathway. However, the presence or absence of outlet obstruction is actually poorly associated with both symptom severity and response to surgery. So most of the time we're aiming to improve symptoms, and we have treatments that are directed at a problem that may or may not have much to do with symptoms. And so the kind of elephant in the room here, if you think about this a little bit, is what about the bladder? This prostatic-centric paradigm, the problem with it is that it largely ignores the primary organ responsible for voiding, which is the bladder. And so this is a critical knowledge gap in urology, and I'll share just two pieces of supporting information for this in the interest of time. And the first is the other half of the graph I just showed a minute ago, which reports a similar age-related increase in the prevalence of urinary symptoms in women, as you can see here, who do not have prostates, but they do have bladders. And so maybe the bladder has a little more to do with this in men than we might think. And the second is some homegrown data here at UW, which is not shown, that shows that bladder strength, or what we call contractility, is a more powerful predictor of a positive response to BPH surgery than obstruction. So what are the tools that we have to assess this? So currently our best and really only test to assess bladder function is multi-channel urodynamics. And this is an invasive procedure that requires placement of both urinary and rectal catheters. And so we place a pressure sensor in the bladder and a pressure sensor in the rectum. And that's the actual data that we collect during the study is just pressure at a single kind of an average pressure through the bladder. And it certainly can be a powerful study, but it's limited. Further, we don't get any anatomic information from it, and so on. And further, it is invasive. As I mentioned, we have to put catheters in. Patients don't like that, and sometimes that's prohibitive. It's limited, as I mentioned, and as a result, it's seldom performed in kind of routine clinical practice for kind of index, LUTS patients, because understandably so, because it's less likely to change management. And so the problem with all of this is that ultimately LUTS is more complicated and probably looks a little more something like this, in which urinary symptoms or LUTs is a confluence of multiple related processes in each individual patient. And so one patient might be here, where they are symptomatic and they have, some underactive bladder or UAB in this diagram. They have some enlargement or BPE, but they're not really obstructed, and then another patient might have a little bit different picture. They are obstructed, but also they have some overactivity of their bladder and so on. And so these are potentially relevant, or I think likely relevant differences, and we need to develop tools to kind of better assess this if we want to advance the field. And so ultimately, our ability to distinguish the relative contributions of these in each patient is a significant barrier, and surmounting that will allow us to offer a more personalized medicine approach and to develop new treatments. And so to that end, the overarching goal of this work is to characterize normal bladder function and to investigate changes in bladder anatomy and voiding performance that occur in men with clinical BPH using novel quantitative MRI techniques. And so we borrowed these MRI techniques actually from tools used for cardiac assessment. And we have developed a methodology to non-invasively characterize the three-dimensional anatomy, wall perfusion, and voiding function of the bladder quantitatively. And so what does this all look like in real life? So the way that it works is the patient comes in to have an MRI. And so they're asked to come in for they're asked to come in for the test with a full bladder. They're fitted with a condom catheter, and they're given a low dose of IV gadolinium about 10 to 15 minutes before the scan to increase the contrast between the urine and the bladder wall. And then once the scan session starts, they're instructed to urinate at any point they feel like they need to. And generally, we run this for about 4 minutes. So they're only in the scanner for 4 minutes, we found is enough time to kind of capture the voiding phase. And from this, we get a wealth of information. And so for starters, I'll kind of walk through how we can use this to recapitulate some of the traditional urodynamic parameters, such as flow rate. And to do that, we use semi-automatic segmentation software to segment the bladder and the urethra along the voiding event. And from that, we can calculate the flow rate based on just change in volume over time. And so we're able to do this, very accurately with 3D modeling, and we plot that over time. And then if we, plot the slope of that curve, we get a rate. And so in that way, we were able to measure the flow rate over time. And we validated this in vivo using traditional non-invasive uroflow imagery. And so you can see here the results of that with the orange curve being the traditional uroflow and the blue curve being the MRI derived. And you can see there's a high degree of concordance there. And so you might be wondering at this point, yeah, but how do you measure pressure with an MRI? And the answer is by using a technique called computational fluid dynamics, which is the particular area of expertise of my collaborator, Dr. Roldan Alzate, who's a PhD scientist in fluid dynamics and mechanical engineering. And so from the in vivo MRI data, the bladder can be segmented over time, and then we can make surface maps, and these data are fed into a computational fluid dynamic model. And then from this, we are able to couple velocity and pressure through equations of fluid motion. And since we can measure fluid velocity at any time and at any with any sort of spatial resolution, we can use this to derive bladder and urethral pressure at any time in the voiding cycle. And so, and we are able to kind of use this technique and translate it in such a way that we can obtain the same data as with traditional multi-channel urodynamics, like I showed you before, the test with the catheters, with great agreement. And so here we see a slide where we looked across a few patients and used kind of the most relevant urodynamic parameters, including maximum flow, PDET, which is the true pressure at maximum flow, and then BCI, or contractility index, and BOOI, which is the obstruction index. And as you can see, these are highly concordant. And so in addition to that, we get a lot of additional information, which has yielded several novel findings. And so first, this is looking at bladder wall displacement, or regional bladder mechanics. This is a 3D contour plot of displacement in real time, showing a healthy versus a BPH patient. And this showed us several kind of novel findings. First of all, which I thought was just astounding, was we always imagined the bladder would collapse like or would contract like a collapsing sphere. In fact, that's not the case. It's more like a piston. As you can see in the healthy control, the dome is drawn down towards the base, and we see a alteration of that in BPH patients. And so we see that these are discoordinated, even though they might be generating the same pressure in the bladder. There's clear differences in how the bladder is functioning, which this technique is sensitive to. And so to quantify that, we segmented the bladder into regions: dome, base, left, right, anterior, posterior, and then measured the regional displacement of each of these. And when you plot that, you can see that there is asymmetry in the contraction in BPH patients compared to control patients. And so what this tells us is that, again, even though a BPH patient, their bladder might be generating a similar pressure as a healthy patient, or even a similar flow in some cases, the bladder is clearly different. There are differences here that we are just now able to see using techniques like this. And this disorganization might be an important and up until now overlooked component of what's driving the disease process. And so in addition, another kind of value added metric from MRI, if you will, is the ability to measure the descent of the bladder into the pelvis during voiding, which is, again, something we're kind of increasingly appreciating as we get to watch these movies. And then also the protrusion of the prostate into the bladder, and the funneling effect of the angle of the bladder neck, during voiding, which is variable. Some people funnel a lot and other people don't funnel as much. And we're looking to see if that kind of correlates with other indices of obstruction and flow. So, and then the last kind of thing that I would mention about this is just as to highlight the kind of information that we up until now have not been able to get at all is an often overlooked component of the lower urinary tract, which is the anterior urethra. So this is the downstream part, the urine channel that courses through the prostate and then through the urethra and then through the penis and then out of the body. And so in a similar way that the volume of the bladder can be segmented, the urethra can be segmented too along the voiding event. And this allows us to study the biomechanics in different regions of the urethra. And so here we see the prostatic urethra, the membranous urethra, and then in the anterior urethra. So the part that goes actually through the prostate gland, the part that goes through the sphincter or the pelvic floor complex, and then the actual anterior urethra. And so just to give you an idea, we're able to measure multiple features, including changes in urethral diameter. And so here we see, during the voiding event, kind of over time, we see the prostatic urethra kind of opens, but we're able to measure that degree of opening and then do the same in the membranous and anterior urethra, and we're able to do that over time. And as you can see, there are changes both within and between subjects. And again, this is kind of in the preliminary data gathering phase. Not sure the significance of this yet, but if we couple that the change in diameter, we're also able to see pressure drops across different parts of the urethra. And so using this, we're able to kind of get additional information about where that that obstruction might be highest, and is it really in the prostate and in all men who are symptomatic, or is it actually kind of in the sphincter complex, or is it more in some than others, and so on. And so we're able to study metrics like this. We're also able to do 3D maps of velocity and wall shear stress in the urethra, as you can see here, and these are all, again, three-dimensional and quite exciting in terms of our ability to just get new information about the lower urinary tract. And so, to summarize, we have developed and implemented a comprehensive, non-invasive MRI protocol to assess bladder biomechanics using a multifactorial relationship. And this is a non-invasive protocol. As I said, it ends up taking about 4 minutes for the patient actually being in the scanner. And this gives us simultaneously information about anatomy and function. And I think this is really exciting because I think it has the potential to supplant the kind of additional or the existing testing that we can offer patients. And I think it perhaps even more so, allows us to get a wealth of information about components of lower urinary tract function that are that are overlooked and we don't really know anything about and are probably quite important actually. And so in the future, what do I think this looks like in the future? I think, from a clinical impact, I think this has the ability or the potential, I would say, to kind of increase utilization of testing such as this kind of earlier in the evaluation process. So you can imagine a future where instead of a patient kind of being referred to you as a urologist for LUTS, they're coming, with, or maybe they're, on LUTS and they've tried medical therapy and so on, but now they're coming with a study such as this one, and you can say, oh, okay, well, this is a patient who has a 34-gram prostate with, 1 centimeter of intraprostatic protrusion. He does not have obstruction on his voiding study, but he does have disorganized kind of bladder contractility and flow vortices. And so for that reason, maybe they would benefit from a minimally invasive approach where we do like a prostatic urethral lift or something like that to kind of change the conformation of the prostate. So that's just like one example of how this might impact. And I think really what it will do is it will allow us to develop new therapy and also better tailor what we currently have to the right patient. And so that's, the idea behind personalized medicine is, can we be splitters instead of lumpers, right? Can we figure out what's going on in an individual patient and then kind of target our therapy? I think it could also help us identify patients who are at risk for progression. That's a common question we get, is patients say, well, I'm bothered, but I don't know, I'm doing okay. But if you tell me I'm going to end up with a catheter in a year from now, then I'll do whatever you say. So can we, and trying to predict that right now, we don't have good tools to do so. And so trying to identify patients who have kind of risky bladders, if you will, would be a powerful contribution. And as I said, the opportunity to tailor surgical therapy. From a research side, I think this allows us to the potential to, we're working on this now, to kind of reverse engineer, if you will, the benefit of outlet procedures. So as I said before, the kind of one fundamental paradox is that a lot of men with symptoms are actually not obstructed, but then they still get better when we do outlet procedures. So what gives? Why is that? Is it like an afterload reduction concept? Are we changing the flow dynamics in some other way that we're unable to appreciate? And so that's an open question in urology. Understand the etiology and impact of port detrusor contractility, which is a recognized entity that we don't do much about because we don't have a lot of relevant interventions for it currently, but that should change. Probe the relationship between the outlet and the bladder and develop new medical and surgical treatments. So with that, I'd like to say thank you for your time this morning, and thank you to my collaborators, Alejo, Shane, Wade Bushman, the O'Brien Center, the members of Caribou, and the whole university, and specifically the Department of Urology. Is really just a fun and exciting place to work, especially when you get to do stuff like this. Lastly, to our supporters at the NIH, this work is funded through an R01 mechanism, and then Alejo and I are both, or he was former K scholar through the O'Brien Center, and I am currently supported through that program. So much thanks to that whole network. And with that, I will stop and welcome any questions that you have.
Thanks, Dr. Grimes. That was really a fascinating presentation. Please, if you're viewing at home, feel free to submit some questions via the chat mechanism. Just because of the number of people viewing, we're not allowing voice questions, but feel free to type it in the chat. We do have some questions that came sort of offline. Why don't you start, while we're waiting for people to put their questions in, Matt, with telling us, how many of these tests have you done, and what is it like, sort of, with is there a learning curve with these? I know anytime I'm an oncologist, so whenever we have MRIs, prostate MRIs, things of that nature, there's this talk about this steep learning curve, and it's hard to, get radiologists on board. But how have you navigated that, and how many of these have you guys done so far?
Yeah, absolutely. So the short answer to your question is, right now we've scanned, as a part of this R01, we've scanned 10 volunteers and 7 patients, so 17 total. Prior to that, we scanned kind of a larger number of volunteers as we were sort of working through all the things that you mentioned, and certainly there was a learning curve. and a lot of, I mean, when we first told you can imagine like the research, the research imaging folks, when we tell them that we're going to have patients void in their MRI scanner, they're like, no, you're not, because you're gonna make a mess, you're gonna ruin the MRI. And so we had to work through a lot of logistical kind of issues with that, which ended up being pretty easy to surmount with a condom catheter and so on. But I would say, so that's kind of one thing we had to work through. Other things that come up are we've actually reduced, I mentioned that 4-minute scan time. We used to do a much longer protocol that was more like 30 to 60 minutes. And we found that just was not, we found that, or I should say Alejo, found that he was able to kind of derive all the information that we needed from just the voiding phase. And so we initially did like a dedicated T2 series before, then voiding, then another one. And we found that those other series were not always necessary. We could actually just kind of get everything we needed from the shorter scan time. But yeah, it's definitely been a learning curve, and there was a lot of kind of preliminary stuff before we were able to kind of get the protocol a little more lean for the study now.
Great. And you spent a lot of time talking about the voiding phase. Dr. Nakata, thanks for your question here. So does MRI Urodynamics provide information about the storage phase? And I think as a follow-up, and in my mind too, I'm thinking, what about in women? Also, have you done any women? Is there value in doing this in the female bladder?
So yes, so the storage phase, yeah, that is a weakness of this protocol. Is right now we aren't imaging patients during the storage phase, and the main reason for that is during a traditional urodynamic study, as we put a catheter in, and so we can measure pressure, as I mentioned, but also so we can fill the bladder and not have it take 2 hours, right? And so right now we've kind of talked about that a lot about if we wanted to study kind of the storage phase, how might we do that? Might we give someone a diuretic, like we do for rhinography to help kind of fill the bladder more quickly? Do we put a catheter in for the purposes of filling and then take it out? Because I think we could, we can measure, as I say, all those metrics. I think would still be valid during filling. The problem is, I think, more kind of a scan time, and so that's a question that we are actively kind of wrestling with right now. Is that it may not tell us as much about kind of overactivity and compliance and things of that nature as a kind of traditional urodynamics does. And then in women, short answer is yes. We've scanned women, and that's actually an important aim of the grants, is to kind of consider that as a variable. As men kind of study men and women, right? To see what differences there are kind of in aging bladders compared to healthy controls.
That's great. Dr. Nakata also has a question about what clinical scenario do you think MRI urodynamics may find its niche? And I think it's a great question, because when you'll have some people saying, well, a man with BPH LUTS that fails medical therapy, do they need any additional testing at all? Or could they go, should they just go straight to a bladder outlet procedure? So where do you think this might fit sort of in the algorithm of diagnostic testing for the patient with lower urinary tract symptoms?
Yeah, it's a great question. I think that, to be clear, I'm not advocating that every patient should have this test or every patient needs, urodynamics, certainly not. I think we don't need to solve we don't need to reinvent every wheel, right? But I do think that where it can be helpful is when there are patients who are being referred to a urologist for consideration of surgical therapy, especially after they've failed, medical treatments, or maybe there's complicating factors like prior procedure, or you're, worried about a contractility, problem. Then I think you can imagine, again, kind of a scenario where instead of seeing someone in the office with a symptom score, you're seeing them in the office with a symptom score, and their prostate volume, the morphology, what their bladder function is like, and so on. And I think that That, so kind of an evaluation of the more complex patient, the kind of non-index patient, if you will, and then kind of thinking farther down the road as we sort of figure out which of these parameters are more relevant, like in terms of which ones are more likely to move the needle and actually change what we do. I could imagine like a more distant future where we move something like this up kind of further in the evaluation process to evaluate those kinds of things where, like a patient is saying, like I mentioned, like I have symptoms and like I'm doing okay, but I want to make sure I'm not going to end up in catheter, dependent retention in 15 years. Am I at risk for that or not, right? So should I have an outlet procedure now or something else now to try to prevent that in the future, right?
Great. I think maybe time for one more question. We are running short on time here. Dr. Borza has asked, have you had the opportunity to perform MRI urodynamics before and after an outlet procedure?
So we have not yet, although we are planning to do so in AIM 3 of our grant. Right now we're recruiting patients from, again, the kind of inclusion criteria are patients with a clinical diagnosis of BPH and then who've had urodynamics. And so the first one kind of makes sense from a science standpoint. The second makes sense more from a practical standpoint because again, the majority of patients don't get urodynamics, and so we're kind of looking at that pool as we're trying to validate this. We need people who have a pressure flow study. And then we have patients, interestingly, once they do it, they get kind of interested. And then some of them have gone on to have an outlet procedure and they're like, hey, can I do that again? That was kind of interesting. We're looking forward to doing that in the future. I think that will be powerful.
Well, thanks a lot, Dr. Grimes. I think we're short on time, and thanks to all the people that tuned in this morning for our first Winnovations lecture. Next lecture will be on September 27th. Dr. Borza, as I mentioned, will be our featured speaker, and look forward to having you all there. And this is really exciting work by Dr. Grimes and his team, and we look forward to seeing where this heads in the future. Signing off, have a great rest of your day.
Thanks, everybody.